for 1 hour. We will take one presentation and then get into the questions and answers. Kindly join the discussions through the chat. That is your only opportunity to join the discussion through the chat, providing questions, comments, and responses to some of the comments that will be running in the chat. We do have language interpretation services. Please keep to either English, French, or Portuguese. Get off the off channel, because then you'll lose out on some back and forth translation services that will be running. Our session slides and recording will be shared with you as soon as they become available. So colleagues, today we focus on low-level viremia during antiretroviral therapy and premised on a study that was done in Uganda, actually multiple studies done in Uganda. We know that from the advent of ART, treatment monitoring for people living with HIV was based on either clinical criteria, and we are quite aware of the WHO clinical staging that was based on some tracer conditions, including opportunistic infections, and also immunological criteria, specifically looking at the T lymphocyte differentiation and enumeration, popularly what we used to just say CD4 and CD8. And that was the immunological criteria. Then we got to the virologic criteria, which was initially quite rare and expensive, but it has become since quite available. We are also aware that in 2013, WHO and other global actors recommended the virologic criteria as the first choice approach for monitoring HIV clients on treatment. And with the viral load testing, the results were generally categorized as suppressed or non-suppressed. When you have viral copies less than 1,000, then you would be categorized as having a suppressed viral load. And then those that had 1,000 and above were categorized. And currently, in some settings, they're also still categorized as having a non-suppressed viral load. But now, we have further gone into disaggregating this dichotomous categorization into undetectable, suppressed but detectable, and then the non-suppressed. And so in today's session, we'll look at studies conducted in Uganda to generate information on prevalence of low-level viremia, how it predicts prognosis, and highlighting some of the potent interventions to shape prognosis and improve individual level treatment outcomes. And of course, the implication of some of the findings on existing policies and practices. And to take us through this, we have Dr. Nicholas Nanyenya. And Nicholas is an international health system strengthening consultant with a special focus on strengthening HIV viral load, early infant diagnosis, and specimen referral programming across Africa. And he has done this work for generally global fund projects in a number of countries, including Sierra Leone, the Gambia, South Sudan, and Ghana, among others. Currently, Nicholas works as a program officer for HIV viral load, early infant diagnosis, and sickle cell programs at the National Health Laboratory and Diagnostic Services of the Ministry of Health, Uganda. Colleagues, join me in welcoming Nicholas to take us through the first segment before we then get into the questions and answers. Nicholas, over to you.
Thank you very much for the kind introduction, and good afternoon, good morning, and good evening, all colleagues who have joined in today's session. And thank you very much for joining in. And in a special way, I want to also welcome my colleague, Dr. Esther Nasuna, who did this work, who is also online. And yes, moderator, kindly confirm that you can hear my voice very well and see my presentation so that I can proceed.
Please do. We can hear you and the slides are clear.
Okay, thank you very much. Thank you very much, moderator, actually, for the kind introduction, but also more importantly for introducing today's topic very well. And as introduced, I'm Dr. Nicholas Nanyenye, Program Officer and an International Health System Strengthening Consultant. Basically, I want to start this presentation with a brief story of a young man who had a desire to see what lay across the countryside. And the only way for him to see what was beyond was for him to climb up a high mountain. And he started on the journey to climb up the mountain. As he was starting the journey, he met a snake, and the snake requested him to carry it so that they could go together up the mountain. And this young man told the snake that I can never carry on to my back because you're a snake and you bite me, and you will bite me anytime. And the snake pleaded with him and he promised not to bite him. And after a few exchanges, the young man got pit on the snake and he carried it on his back. And as they went up the mountain, they went conversing. After a few days of hard work, this young man was able to reach on top of the mountain together with the snake. And as he was just starting to see what was beyond the countryside, the snake bit him, as we can all see in the third photograph. And it was a very poisonous snake, and the poison spread across his entire body, and he lay down. And as he was dying, he told the snake that you promised that you would not bite me. And the snake told him that I'm a snake. What did you think? So this is just a brief story, meaning that a snake is always a snake. Whether it says that it will not bite you, when it reaches its comfortable zone, it will bite you. And likewise, a virus is a virus. In any amount in the body of a human, it remains a virus. Whether we want to say that it is very little or very small and it won't cause any harm, it's a virus. And that is, it's a virus and it can cause harm to our clients. And imagine an innocent man who's taking his drugs very well. And this innocent man decides to go and test for viral load. And the results are returned and his viral load is 400 copies per mil. 400 copies per mil is in the range of low-level viremia, which is between 50 and 1,000 copies per mil. In many health facilities in sub-Saharan Africa, this innocent man will be informed that the drugs are working very well and he will be sent back home happy. But only a few months later, this innocent man may develop treatment failure. And this brings us to a question whether we are providing optimal care to our clients in Africa. And of course, that's for us to think about, and it forms the basis of our presentation today. And in this presentation, we are going to basically look at low-level viremia and whether it should worry us. And by low-level viremia, we mean a viral load which is low but detectable. That is 50 copies to below or less than 1,000 copies per mil. And then all of us know viral load as the number of HIV viral copies per millimeter of blood. And then a suppressed viral load will mean a viral load less than 1,000 copies per mil as per the WHO guidelines. And then a non-suppressed viral load will mean a viral load of 1,000 copies per mil or more. And intensive adherence counseling will mean targeted counseling offered to people living with HIV having a non-suppressed viral load. And then a non-detectable viral load will mean a viral load result below 50 copies per millimeter of blood. And in 2022, globally, 630,000 people died due to HIV-related causes, and 1.3 million people acquired HIV, and over 60% of these were in sub-Saharan Africa. And of course, this shows that HIV is still a big burden in the region, which we have to devote efforts together to address. And if we take an example of Uganda in 2021, 17,000 people died because of HIV, and another 54,000 people acquired HIV in Uganda. And this is not different from the other sub-Saharan African countries, which share similar contexts with Uganda. And as we know, when the virus enters into the human body, it moves into the CD4 cells. And the number of processes there, from fusion to reverse transcription, integration, then to budding, among others. And the drugs that our clients take work to inhibit some of these processes. But when our clients are taking these drugs, we want to test these clients and see whether the drugs are working very well. And we very well know that in 2013, the World Health Organization recommended viral testing as the preferred tool for testing efficacy of art. And between 2014 and 2015, a number of sub-Saharan African countries initiated viral testing as a program. And a threshold of 1,000 copies per mil has been recommended for non-suppression in most of the sub-Saharan African countries. However, when you look at other international organizations like CDC and the International Association of AIDS Care, for them, they recommend a threshold of 200 copies per mil. And in some of the European countries, it even goes below. Their thresholds are even 50 copies per mil. But in sub-Saharan Africa, most of the countries are still using 1,000. And the research has shown that people who have between 1,000 copies per mil and 50 copies per mil, which is low-level viremia, have increased the chances of treatment failure, increased chances of HIV drug resistance, and then increased chances of transmitting the HIV virus. One specific study done in South Africa by Hans and others showed that actually people with low-level viremia had 2.6 chances of biological failure. And then another South African study done in KwaZulu showed that actually mothers who had low-level viremia had 10-fold increased the chance of transmitting this virus to their children or their newborn babies. But here we are still using 1,000 copies per mil for non-suppression. And of course, when you look at Uganda, our program data showed an increase of people having low-level viremia in the country. And this is not different from the other African countries, more especially in the sub-Saharan region. And despite this, prior to this study and prior to 2022, there was no intervention being done to address low-level viremia in the region and in Uganda inclusive. And the main goal of this study was to generate information which would guide Ministry of Health in Uganda to review the viral testing algorithm and also institute interventions to manage low-level viremia within the country. But also, we were optimistic that this information would help other ministries of health with similar settings as Uganda. And we did a comprehensive literature review of the available data, and we were able to publish this paper in the African Journal of Laboratory Medicine, which is luckily hosted by ASLM, and members can look at that and get some insights. And like I indicated, the main rationale of this study was for us to generate information which would guide Ministry of Health and its partners to review the HIV guidelines to be able to control low-level viremia in the country, because we realized that low-level viremia frightened the country's progress to control the AIDS epidemic by 2030. And we basically had 3 objectives. The first one was to determine the association between low-level viremia and viral suppression among people living with HIV from 2016 to 2020 in Uganda. And this constituted our sub-study 1. And then the other objective, we wanted to know what people living with HIV and healthcare providers thought about low-level viremia in the country. And this was as sub-study 2, which was a qualitative study. And then the last one, we wanted to determine the effectiveness of intensive adherence counseling in achieving a non-detectable viral load in management of low-level viremia within Uganda. Of course, we know that intensive adherence counseling has been recommended now by WHO as an intervention for people living with low-level viremia, but there is limited data on whether it is effective or not. And this is what we aimed to produce in this objective. And this was a study conducted across all the 4 regions of Uganda. And the results from our first objective were published in PROS 1. And when these slides are shared, I will also request members to look at these results in PROS 1, very insightful, but we're also going to have a brief snapshot about them. And basically, in the first objective, which was to determine the association between low-level viremia and violence suppression among people living with HIV in Uganda, basically, this was a retrospective cohort study, and it involved the people living with HIV who had a suppressed viral load. Whether they had low-level viremia or an undetectable viral load, they were involved. And their viral load had been done between January 2016 and December 2016 using plasma samples. And we used the National Viral Load Program data, and we categorized these people into 2 groups. The first group comprised of people living with HIV who had a non-detectable viral load, and this was the non-exposed group. And then the second group was those people who had low-level viremia, suppressed but had low-level viremia, and this was the exposed group. And of course, in the data analysis, I said it was a retrospective cohort study. In the data analysis, we used multivariate logistic regression to determine the factors which were associated with low-level viremia. And then we used the survivor analysis methods, mainly Kaplan-Meier and Cox proportional hazards, to determine the association between low-level viremia and violence suppression. Important to notice that we use program data, as I indicated, and you know the challenges with program data. There is a lot of missing data. So we used multiple imputation to manage the missing data. And we basically looked at the proportions of HIV people with violence suppression among the exposed and the unexposed groups. I say the exposed group was comprised of people who had low-level viremia, and then the non-exposed was comprised of people who had a non-detectable viral load. And to break it down in brief, we wanted to see how many people who have low-level viremia will get violence suppression, and how many people who have a non-detectable viral load will get viral non-suppression. And of course, we looked this from 2016 up to 2020. And we also got the time to non-suppression and hazard ratios as the other outcomes. And our results indicated increasing proportions of low-level viremia from 2% in 2016 to 8.6% in 2020. This was from the general data set it was, but when we went down to get the cohort according to our criteria, those who were suppressed and having plasma samples. So in the baseline year, which was 2016, we had about 612,006 people tested, and we excluded all those who were non-suppressed. We also excluded all those who had DBS samples. And the reason as to why we excluded those who had DBS samples is because by then the platforms were using, first and foremost, they were not giving absolute values, but then they had higher limits of detection. I think about 800, 300, and about 839 copies per mil. So that's why we excluded them. And then we excluded all samples without definite results, those that had less, because they were not exact. And then we excluded all the lost to follow-ups, those who didn't have valid results for all the years and the date of sample collection, and we remained with a cohort of 17,783 people who were followed up from 2016 to 2020. And still in the results, we learned that men had a 1.3 times the risk of having low-level viremia as compared to women. And the results were significant, as we can see the p-value. And then those on second line had 2.5 times the risk of having low-level viremia as compared to those on first line. Still results were significant. And the children had increased the risk of low-level viremia as compared to adults. And that is a table which summarizes the study characteristics of the cohort that we took on. And the results, our median follow-up time was 4 years, and nearly 1 in 10 people became non-suppressed during the follow-up period. That is 9.7%, which constituted 1,730,000 people who became non-suppressed in both groups. However, important to note is that 32.5%, which was 476 out of 1,466 people, of the people with low-level viremia became non-suppressed, as compared to 7.7% of people who had a non-detectable viral load. So that is already a key highlight. The proportions are too large, and of course the difference was significant. 32% of those who had low-level viremia became non-suppressed. Only 7.7% of those who had a non-detectable viral load became non-suppressed, and the results were significant. And then people with low-level viremia had a 4.1 risk of developing viral non-suppression as compared to those with a non-detectable viral load, and the results were significant. And the Kaplan-Meier also showed increased probability of viral non-suppression at any one time in the low-level viremia group as compared to the group with a non-detectable viral load. And this increased with the increasing levels of viremia. Those who had the high levels of the virus in the blood, like 900, 600, had increased the chances of becoming non-suppressed as compared to those who had lower ones. And the conclusions from this study were basically increasing number of people with low-level viremia from 2% in 2016 to 8.6 in 2020, and then increased the risk of 4.1 of developing viral non-suppression among people who have low-level viremia as compared to those with a non-detectable viral load. And then low-level viremia was associated with male sex, second-line regimen, and lower age. And the recommendations that we made to our Ministry of Health, but which recommendations also go to our respective ministries of health, is that there is an urgent need for us to review our viral load testing algorithms. Of course, in Uganda, we reviewed our guidelines, and the viral load threshold was reduced from 1,000 to 200 and 400 copies per mil. 200 for plasma and 400 for DBS samples. And of course, this recommendation goes to World Health Organization, which I know is also attending this session. There is need for us to review the recommendation of using 1,000 copies per mil to determine viral non-suppression in sub-Saharan African region. Of course, we know there are a lot of other factors that have to be put in consideration, like the cost, the public health perspective, among others. But if we are to attain epidemic control by 2030, we need to review this and review this recommendation and give other guidance which may be suitable to enable our countries achieve epidemic control by 2030. And in objective 2, which was a qualitative study and whose results are published in PROS Global Public Health. Of course, this was exploring the perceptions of low-level viremia among people living with HIV and healthcare providers in Uganda. And this was a qualitative narrative study using the health belief model. And we involved people living with HIV, people who had been on ACT for 6 months or more, 18 years old and above, and who were able to speak the commonly spoken languages in Uganda. And then we also involved the healthcare workers providing HIV care. And we conducted 32 in-depth interviews with the people living with HIV and 15 key informant interviews with health care workers. And we collected data from 8 high-volume facilities having high numbers of people living with HIV with Viremia. And we used the thematic analysis with help of Atlas TI to analyze the data. And the main outcomes were basically perceptions of people living with HIV and healthcare workers about Viremia, and then the meaning of Viremia and viral load among people living with HIV, and the meaning of these among healthcare workers. And these were the participant characteristics. And we had a number of themes. Basically, 7 themes emerged out of the analyzed data. And this summarizes the themes, which we can look at in details when the presentation will be shared out. And looking at the results, the meaning of Viremia. Most of the people living with HIV were not aware of the term Viremia. And when we try to break it down to them and put it in terms of numbers, that is asking them what they thought about a viral load between 50 and 999 copies per mil, they perceived it as a decreased and suppressed viral load. And they said it was very good and it's what they actually wanted to have. For example, one of them said that if you achieve Viremia, there will be a lot of joy and thanking God Almighty very much. After realizing that you don't have to start worrying or doing other things, but you have to keep your life very well as you ought to. So for this client, having Viremia, they would go to the church or mosque and do a Thanksgiving, and not knowing, of course, what implications it had in their life. And those that had no education, like I indicated, thought that this was a motivation for them to take their drugs. However, a few people living with HIV who had a secondary and tertiary education actually knew that Viremia was not good, and they said that it was caused by not taking their drugs very well. And when we asked them about the meaning of viral load testing, of course, I should say that in Uganda, we have a little more mature viral load program, and intensive awareness has been created. So on the side of viral load, people living with HIV knew what viral load meant, and they knew its benefits very well. And of course, they hinted on the challenges which are similar almost in everywhere: stigma, myths, personal challenges like poverty, conflicting priorities, and then health system challenges like few health workers, long waiting time, among others. Those were some of the challenges they hinted. And then when we asked them about the facilitators to viral load testing, of course, they hinted on the need to increase the number of health workers facilities, need to create more sensitization, additional government support, and having continuous reminders, which I think is very much similar in all our contexts. And when we went to understanding of Viremia among healthcare workers, nearly all the healthcare workers at the different HIV clinic could not define what Viremia was. And many of them interpreted it as having a suppressed viral load, which was right, but not definitive. And when we try to break it down into numbers, a range between 50 to 99, they described it as a range which was caused by suboptimal adherence. And of course, they indicated that people living with HIV having low level viremia had increased risk of violence suppression and HIV transmission. And they say that if someone has low level viremia, sometimes they cancel them to continue taking their drugs very well, and at other times they don't cancel them. So the canceling was very informal and unstructured. And the main conclusions from this study were mainly two. Many people living with HIV were unaware about viremia and did not understand its risks. And then healthcare workers did not fully understand viremia and its implication. And they say you give what you have. So if you're a health worker and you don't have knowledge about a given condition, meaning that you won't educate your client or your patient, and likewise, you won't give the necessary care to your client or patient. And the main recommendations from this study to the ministries of health and the partners, there is need for the ministries of health to sensitize health care workers and people living with HIV about viremia and its associated risks. And then there is a need. Of course, our studies didn't focus on stigma, but when you are talking with people living with HIV, one of the things that comes out strongly is stigma, and we need to devise strategies through our ministries of health to reduce this, but also improve our viral results turnaround time. And then to the World Health Organization, there is need for WHO to devise strategies to guide countries on how to create awareness for viremia. Of course, WHO has acted by instituting viremia as an of course, World Health Organization has acted by instituting intensive adherence counseling as an intervention to manage viremia, but there is still need for WHO to still come up with proper guidance on how to create awareness for viremia. And then in the third objective, which was a clinical trial, these results were published in HIV medicine, and we can look at them in details. And we basically wanted to determine the effectiveness of intensive adherence counseling in achieving a non-detectable viral load in the management of viremia among people living with HIV on treatment in Uganda. And this was a cluster randomized clinical trial, which involved people living with HIV on earth who had recent viral results with viremia. And here we had two groups. The intervention group, where we offered these people intensive adherence counseling. People having viremia being offered intensive adherence counseling as it is recommended. And then people having viremia who are not offered any intensive adherence counseling. And then the study ran for 3 months. The ISCE was for 3 months. The people in the intervention group were offered ISCE for 3 months, after which a repeat viral load was done in both groups. After 3 months, in the 4th month, a repeat viral load was done for people in the intervention group and for those in the control group. And of course, we used bivariate analysis and modified Poisson and Cox regression to analyze the results. And we were basically looking at proportions of HIV people, proportions of people living with HIV with viremia, achieving. I know that a non-detectable viral load is recommended by different international organizations as the ideal. And as I hinted that most countries are already using a suppression threshold of below 50. So that was our main outcome. If you have viremia and you are offered intensive adherence counseling, will you achieve a non-detectable viral load? And this was compared to those who were not offered intensive adherence counseling in the control group. And we looked at risk ratios and hazard ratios. And this was the flow of the study. And these were the characteristics of the study participants. And looking at the results, our participant retention was very good. The average follow-up time was 3.7 months, and 100% of the participants in the intervention group completed all the 3 sessions of intensive adherence counseling and actually did the repeat viral load. And 98.5%, 67 out of 68 of the people in the compulsion non-intervention group, which is the control group, did a repeat viral load. There was a lost follow-up of one participant who was transferred to another clinic which was distant. And when we made efforts to try and trace the participants, all the known phone numbers were off. And a total of 59 people living with HIV, which constituted 43.7% out of 135 participants, achieved a non-detectable viral load. So in both groups, 43.7% of the participants achieved a non-detectable viral load. And the effect of intensive adherence counseling on attaining a non-detectable viral load was near as twice as high in the intervention group as compared to the non-control, as compared to the control group. 57.4% of the people in the intervention group achieved a non-detectable viral load, as compared to 29.9%, which was almost twice. And the risk ratio here was 1.9%. So meaning that those who were offered intensive adherence counseling had increased the chances of attaining a non-detectable viral load as compared to those who were not cancelled at all. However, more interestingly, this is where I want to put a major emphasis that these people have low-level viremia. We call them suppressed. And we would expect that if you cancel them very well, over 90% of them would get a non-detectable viral load because they're already suppressed. But it's alarming that it was only 57.4%. So there is a big question mark here. Is the intensive adherence counseling that we are offering to our clients still working, or there is need for us to review it? And could there be some resistance that is going on even with viremia? Someone has viremia, but they have started having resistance. And of course, studies have shown this. And this was a shortfall in our study that we didn't test these people for viremia. Sorry, for HIV drug resistance, because we might be thinking that they are not adhering, yet they have started developing HIV drug resistance. And this was a Kaplan-Meier, which also showed the same results. People living with HIV in the intervention group had a 3.2 times the hazard rate of achieving an undetectable viral load. And the main conclusions from this study indicated that intensive adherence counseling doubled the likelihood of achieving an undetectable viral load among people living with HIV having low-level viremia. And then this is something we noted. Of course, many studies have indicated that retention during intensive adherence counseling is very poor. And of course, this partly explains the low success rates of intensive adherence counseling, even for the non-suppressed. But in our study, we gave a small incentive, which was a transport refund. And we think this improved the retention during these intensive adherence counseling sessions. The main recommendations to our ministries of health, there is need to institute intensive adherence counseling as an intervention to manage people living with viremia. Of course, I indicated that WHO has already recommended this, but most ministries of health are still complacent about instituting this, and we need to institute this. In Uganda, this has been instituted, as I highlighted earlier. And then there is need for our ministries of health and researchers to conduct implementation science studies to design effective and sustainable interventions to manage people living with viremia, in addition to use of intensive adherence counseling. But we also need other studies to study and improve how intensive adherence counseling is offered, because of course there are so many other studies which are showing that it is not very effective as we would want it to be. It has low success rates, so we need to do other implementation science studies to improve it. And then to the World Health Organization, there is need for WHO to give elaborate and clear guidance about the use of intensive adherence counseling to manage people living with viremia. Of course, they gave the guidance that if people have a range of viral load that falls in viremia, we should institute for them intensive adherence counseling. But the main question is how long? If someone has it the first time and we cancel them and we retest and they still have low viremia and we continue again, it's cyclic. So to what extent should we maybe think about switching or do HIV drug resistance? So there is need for that clear guidance from WHO to our countries. And of course, I'll skip this in the interest of time. But one of the main limitations was that we didn't do HIV drug resistance in this study, which is key because someone could be having low viremia, but at the same time also having HIV drug resistance. And then data missingness was very, very high. And the policy implications are, of course, a reduction of viral suppression threshold is very key. If we reduce the number of people living with HIV having low viremia, that's very key. And then we need to sensitize people living with HIV and healthcare workers about low viremia and how it can be handled. And institution of ISCE in management of low viremia is very key. But also more importantly, of course, we know that in our countries, we've been at stages where we wanted to scale up viral testing and we didn't care very much about the platforms. At a certain level, it was a yes or no. Are you suppressed or you're not suppressed? But given that we have tried to scale up viral testing in our countries, we also now need to look at the platforms that we are using. For sure, there are those platforms which are having higher levels of detection. If a machine can't see any virus below 500 or any viral copies below 800, and here we are talking about virtual elimination of HIV, virtual elimination of vertical transmission of HIV. And this mother has 700 copies per million and we can't detect and do the necessary interventions. I think that puts us really behind and backwards in these efforts against HIV. So we need to review the viral testing platforms and encourage our colleagues in industry to try and improve the platforms so that they can have lower limits of detection. 20, 50 copies per mil, that would be good. That would be good. And then implications for further research. Of course, I already hinted about this in the previous slides, and I'll skip them in the interest of time. And just a special acknowledgement to Minister of Health Uganda, that is the Department of Laboratory Services where I work, and then the Makerere University, the Fogarty programs, and then the different colleagues for working together for us to do this research. Thank you very much. Over to you, Chair.
Thank you. Thank you very much, Nicholas and team. And again, to appreciate you and the team for a very informative presentation. I know that these are actually 3 presentations in one, but you connected the 3 quite well and you went it alone. So thank you again very much. I have taken a few things, and in the interest of time, I will not highlight all. But I know that you stated in the beginning that a snake remains a snake and a virus will remain a virus, whether they're in small copies, small amounts in circulation. they will remain a virus and they will try and disturb the body. We also know that over time, people living with HIV and have low-level viremia survive poorly compared to those that have non-detectable viral load, and that is the 50 or less copies per mil. And so grouping those that have low-level viremia with those that have non-detectable viral load is probably doing a disservice to those that have a low-level viremia. And again, this data is coming through and reinforcing what probably has already been discovered in other places. And so this really reinforces the information that is available out there and some of the recommendations that you're making that are being also put out there by the global actors. And so we have some few questions that are coming through. But before we get into the questions, I just wanted Lara to make a quick comment. Fitsam kindly confirm that Lara has capacity to unmute. Lara Voinov, if you could just make a quick comment before we open up to the questions and answers.
Certainly. Hi, Francis. I hope you can hear me okay.
Perfectly well.
Wonderful. So first, Nicholas, thank you for this. This was an excellent presentation. And indeed, I think there's been some indications of this from other countries and other studies. I put in the chat, funny the timing that this works, but in July of last year, the WHO did generate, when I was with the WHO last year, we generated a policy brief that touched on this important issue and looked at the differences between an undetectable viral load, a suppressed viral load, and an unsuppressed viral load. And so hopefully some of the answers, some of the thinking that you're suggesting are included in that in terms of how to communicate having a suppressed viral load. So that means it's the same as having low-level viremia, but providing it in perhaps layman's terms, which there are some benefits, particularly around almost zero risk of transmission for those who have a suppressed viral load. And my only note of caution that I might suggest as you and other countries start looking into this in your countries is really thinking about and understanding your implementation of dolutegravir-based regimens. We do understand the patient level risks of low-level viremia or a suppressed viral load, and I think you indicated them very nicely. And you mentioned the study in South Africa. That study in South Africa was done using non-dolutegravir-based regimens. So the older regimens using nevirapine and others that we know are not as effective as dolutegravir. Dolutegravir has a very high barrier to drug resistance. That doesn't mean there's none, but it does mean that there's a high barrier. And so interpreting low-level viremia results and the impact of them on the clinical and patient needs is really important. Understanding, for example, in your study, if and how many of those people living with HIV were on dolutegravir-based regimens. And so we're still, WHO and others, still looking to understand whether low-level viremia still has a role, a clinical role, for those on dolutegravir-based regimens, given that high barrier of resistance. So being a little bit cautious and thoughtful as to whether or not you make significant adjustments to your treatment monitoring as countries are also implementing this optimal drug that seems to be working considerably better than the others and doesn't drive drug resistance quite as significantly. So maybe a note of caution as you and others dive down the suppressed viral load realm, but also including some of those positive messaging from the policy brief that I shared earlier. Thanks so much, Francis, and happy to answer any follow-up questions if they arise.
Thank you. Thank you very much, Lara, for those additional comments to the very exciting presentation from the Ugandan team led by Nicholas. Nicholas, we have a few questions or comments, and I'll start with one that is coming in from Gebisa, and Gebisa is asking, how could low-level viremia contribute to treatment failure unless the clients are not adhering to their regimens?
Okay, thank you very much. Of course, thanks to Dr. Rada. She was a big inspiration in this work, and thanks to her also for attending the session and for sharing the policy briefs. And then back to that question. Of course, we know that one of the causes, there are probably two causes of low level viremia. The first one is suboptimal treatment adherence. But then the second one could be HIV drug resistance. And of course, all these are supported by literature that they can happen. But when a client has low level viremia and they are taking these drugs and the virus remains into their blood, eventually it becomes exposed to the virus and it keeps mutating, and eventually it will become resistant. If the cause was because the patient is not taking their drugs very well, when it remains in the blood and it becomes exposed to the drugs routinely because the patient is not taking them very well, in the long run it will become resistant, and when it becomes resistant it will start replicating at high levels, and eventually the patient will run into treatment failure. Yeah, over to you.
Thank you. Thank you very much, Nicholas. We have a few more questions that are coming in, and I'm very mindful of our time as well. But Ernest is asking whether completing all 3 sessions of IAC is not a challenge in Uganda, because to him, completing these 3 IAC is a big challenge in most health facilities in Cameroon. And so for you in the study, you indicated 100% completion rate. I know that you indicated that for this particular study, there was some incentive that was being given to participants to allow them get transport and return to the facility for IAC. But in general, care for clients in Uganda that are going through IAC, what is your experience with adhering to IAC completion?
Thank you very much for that wonderful question. Actually, retention in ISCE is a big challenge. Even in Uganda, it's still a challenge that these clients don't come back for the sessions as they ought to come back. You cancel them today and you schedule them for another session next month, and you won't see them for the next 2 months, and then they'll come back after 2 months and you have to repeat again. You talk to them, cancel them, and this is a big challenge that is affecting intensive adherence counseling. But also, as I indicated, ISCE itself has a low success rate, which literature has shown, but which we are also seeing over time. And of course, there is need for global actors. Dr. Lala is here, and the other colleagues from the global sector to give a little more guidance on how ISCE should be done. Otherwise, it's a nightmare, not only in Uganda, not only in Cameroon, but even in so many other countries.
Thank you. Thank you very much, Nicholas. And I don't know if your colleague can support you. If not, you'll go it alone. But we are almost reaching the end of this. And I know that there are many more questions coming in. I just wanted to ask one question related to what Lara was indicating. And I know that the study population and the time that you were doing the study spanned from 2016. And depending on when Uganda rolled out DTG, is it possible that at some point you can also disaggregate your data to look at the performance of low-level viremia with the old regimen versus how it is performing with the new regimen that now is based on the DTG based regimen? I do not know if you have just some thoughts around that. Nicholas.
Okay, yes, thank you very much. Of course, I want to agree with Dr. Lara that DTG's plans on DTG have high barriers to resistance, and for this study, for example, for the first study, when 2016 to 2020, DTG had not been completely rolled out across the country, and most of them were on the other non-DTG regimens. But I should strongly highlight that in Uganda, we are doing a study to determine the prevalence of HIV drug resistance among clients who are on DTG and having low level viremia. And anytime soon, as Uganda and partners, we shall be sharing those results, I think, here in LabCoP. And that will be an interesting study to look at. Yes, over to you.
Thank you. Thank you very much, Nicholas. My chat is buzzing, and just to confirm with colleagues that should we not get to answer all the questions, we'll pick them and send them to Nicholas or whoever can provide us the answers, and then that will form part of the package that we'll be sharing with you when we share the slides for this presentation. The second last comment, there is one from Eric Okek, and Eric is asking, what is your comment on the reintroduction of immunological marker, such as CD4, in the monitoring of HIV disease progression and prognosis? If you could just quickly chip in there, and then I will give you the last question as we prepare to wind it up. Nicholas, over to you.
Okay, thank you very much. Thanks for that question. That's a very good question. Of course, we know that in our programs, we've now started putting stronger emphasis on advanced HIV disease. Originally, when Virus came in, we seemed to have thrown away other monitoring methods like CD4 monitoring. And of course, that has hit us back. It has hit us back in a way that some of the clients, despite having a very good viral load, are having other issues, which viral load alone cannot diagnose, but you need a CD4. And of course, in Uganda, we are strongly devoting efforts to put strategies for monitoring of advanced HIV disease. But also, immunological markers like CD4 are still important. For example, in most of the countries I've gone to, they have still upheld that recommendation of doing CD4 for all those people living with HIV who are starting at, and of course it's very key for us to when people don't present with the expected viral results, for us to think about CD4. It can help us really in proper monitoring and management of these clients. But I think that is a big question to WHO to try and see the role that CD4 has in the current arena of HIV and in the era of viral testing. Of course, I know WHO has given guidance, but probably we may need to revisit that guidance.
Thank you. Thank you very much. I do not want to stop, but we have to stop at some point. And so, Nicholas, just for your parking lot, we know that in your interventional study, you provided the intervention, which is IAC, to the intervention group, and then the standard package of care to the control group. I just wanted to know that study population had low-level viremia. But was that low-level viremia the first time low-level viremia, or because there are those who are non-suppressed, and then they go through the routine intensive adherence counseling, and then they still come back as suppressed, but with low-level viremia? That is a slightly different study population. Okay, different population. So at some point, I'll ask you to break that down for me. If you took every low-level viremia client, or you had to disaggregate those that were first-time low-level viremia, or those that were actually low-level viremia after the first intensive adherence counseling that was provided routinely. Colleagues, thank you for joining us. I will just give my good friend Nicholas 1 minute to give us his closing remarks.
Yes, thank you very much, our moderator and the PM for moderating the session and for inviting me to share these very good results with the LabCoP community. And special appreciation to everyone for attending. Special appreciation to Dr. Lala for attending this session. And when we published the first paper in, I think, 2021 or 2022, I realized that a number of countries accessed the paper from the African Journal of Laboratory Medicine, and they initiated some of the researches. I know Kenya has done one, Nigeria has done, and a few other countries. And my humble request to the countries here is that so we have some of this data with us. Let's try to see how Viremia is affecting each of our countries so that we may help our clients living with HIV. Otherwise, I want to thank you very much, and thanks to the ASLM community for this opportunity. Over to you, Chair.
Thank you. Thank you very much, Nicholas, and your wonderful team for this very great work. And then thank you to everyone who has been with us from the start to the end. Please be on the lookout for our next session. That will also be another very interesting one. And from us to you, do have the best of your day, evening, or afternoon, wherever you're joining us from. Thank you and over.